So Guyana, not Ghana in South America. Guyana is not Ghana in Africa. Guyana is in South America. It is 216,000 square kilometers and is the only English-speaking country in South America. It lies on the northern coast of the continent. Neighboring Venezuela is your gateway to Brazil and the World Cup football. Next door to Suriname and the Atlantic Ocean. And historically and culturally, we've shared close ties with the Caribbean islands. And years ago, Guyana was labeled as one of the 4 more developed Caribbean countries, the others being Jamaica, Trinidad and Tobago, and Barbados. And in 1973, these 4 countries founded the Caribbean community known as CARICOM, and it's headquartered in Guyana. And in 2008, we tried to strengthen our ties with South America, and we became a member of the Caribbean Union of South American Nations, UNASUR. And since independence, Guyana has maintained strong political ties with Cuba, China, and India. And the majority of our medical specialists come from these countries. The main foreign exchange earners are gold, sugar, rice, and bauxite. But we also export timber and other agricultural products. The challenges. This resource-limited lower middle-income country has a population of just under 3/4 million, 90% of whom live on the low-lying, flat coastland, with tiny villages scattered among the mountains and rivers of the Amazon rainforest, which covers 70% of the country. And while this is a nature lover's paradise, it is a governance nightmare. There are fairly decent roads along the coastland, but our inland roads are few and are not optimally maintained. This has prevented fuel going to the interior to Lethem, so they had blackout for days because of this road. The name Guyana is an Amerindian word for land of many waters. We don't get drought. We don't know what that is. Our rivers are a vital source of livelihood and transportation for our indigenous Amerindian people. Communication in the hinterland is hampered by the paucity of telephones, electricity, and internet access. And furthermore, our 9 Amerindian tribes each have their own dialect. And our borders are porous, so the persons living along the borders speak Dutch, Portuguese, Spanish. And then we have our native English, which we call Creolese. So it's a multilingual society. Guyana never fully recovered from the economic decline of the 1970s. And despite an abundance of a range of natural resources, Guyana is now, shamefully, one of the poorest countries in the Caribbean. Those are all of these are Caribbean territories. The only one who's not here is Haiti. One of the poorest countries in the Caribbean and the Western Hemisphere. And servicing our high debt burden left little funds available for national development. This resulted in crumbling infrastructure. This is our main referral hospital at that time. The brain drain, which started in the 1970s, continued unabated, with few, if any, fully trained Guyanese medical specialists returning to Guyana in the 20-year gap between the mid-70s and the mid-90s. There was multi-sector-wide decline in human and material resources. By the early 1990s, don't know if you recognize that is the map of Guyana. It's not upright. It's on the side. It's on the brink of the Kaichor Falls, which is the largest single drop fall in the world, we were told. The health sector was teetering on the brink of disaster, as eloquently captured by a local popular satirist. And this is what was happening in those days. Your relative has just been admitted to hospital. The funeral will be next week. Our strategies. As a highly indebted poor country, we were given significant debt relief in the mid-90s. The government promptly invested heavily in infrastructure, building more roads, especially to previously isolated communities. New health facilities were built all over the country and equipped with modern, state-of-the-art equipment, solar-powered electricity, satellite phones, and wider geographic spread of cell phone towers greatly improved communication in the hinterland. Government recognized health as a priority and steadily increased their financial commitment towards realizing our vision that Guyanese be among the healthiest in the Caribbean and the Americas. To counteract the brain drain, class sizes of training programs were increased, and persons were bonded to serve the government for 3 to 5 years. Unfortunately, the rate of graduates migrating also increased, resulting in little change in the doctor-patient and nurse-patient ratios. The deteriorating school leaving exam results caused a reduction in the number of persons who met entry requirements for health sector training programs. Entry requirements were therefore lowered, and in addition, lower categories of staff were simultaneously trained. Substitution was implemented on a large scale in order to produce a trained workforce in a shorter time frame. These graduates have now become the bedrock of our health sector. In other words, the majority of nursing care in Guyana is not delivered by registered nurses, but rather by nursing assistants, single-trained midwives, patient care assistants. Registered pharmacists are in the minority. These could work if they have enough protocols, guidelines, and adequate supervision and monitoring, which is absent. The critical lack of medical specialists was addressed via intergovernmental agreements with the Cuban and Chinese governments, while Indian nationals filled that gap in the private sector, to the point where foreigners comprised 90% of our specialists. And now I come to the anesthesia story. This story begins in the mid-90s, when 3 Guyanese graduates of the anesthesia doctoral degree of the University of the West Indies, Jamaica, returned to work at the Georgetown Public Hospital. Alexandra Harvey was the first to return in 1995, and she was appointed head of department. Her name has now become synonymous with anesthesia training in Guyana. In the center is Monica Odwin-Sagala, and she's currently the Director of Regional Health Services and member of the Medical Council, and on occasion acts as the Chief Medical Officer. Well, I am the pretty one in the picture. I got a phone call from Alex. I was in the UK at the time. I'm alone. I need help. And guess what? There's a Nigerian doctor in the department. Come. So I jumped on the plane and I went down to Guyana. He's home right now with the kids. So we arrived and we were about to embark on what has become professionally the most rewarding and exciting adventure of my life. And I've had many adventures. And this is the adventure. It starts with Monica's thesis. She focused on assessing the human and material anesthesia resources in Guyana in 1994. At that time, the anesthesia providers consisted of 2 specialists, one from Cuba, one from China, a diploma graduate, a Chinese resident in training, and 5 junior doctors with training periods ranging from 1 to 9 months, and 11 nurses whose training periods range from 6 months to 3 years. Our anesthesia safety practices were poor, with the inevitable consequences. That was the equipment that was being used in the country at the time. The alarm was finally raised in 1993 following a public outcry after there were apparently 3 anesthesia deaths in 2 days at the Georgetown Public Hospital. The Ministry of Health heeded the advice of invited overseas experts. And by 1996, courtesy of a World Bank loan, a modern state-of-the-art ambulatory care and diagnostic center wing was opened at the Georgetown Public Hospital. It included a well-equipped 6-room operating theater suite with an 8-bed recovery room, a 7-bed ICU, and a 10-bed high-dependency unit. And Monica and I both returned to Guyana a few months before this was opened, so we were there at the beginning. We had fun. We implemented the following safety initiatives, and these have been sustained over the past 18 years. Oh, sorry, went backwards. Good. Last year, we started a pre-assessment anesthesia clinic. The consent for surgery was a big fight, but we won that boxing round against our surgical colleagues, and we continue to win other boxing rounds against them. We are champions. We had multifunction monitors to aid with our intra-op vital sign monitoring. We got to design our own anesthesia charts. We had our regular departmental meetings with morbidity, mortality, audit, journal club. Those meetings have fallen by the wayside a bit. They're not as frequent as they used to be because of trying to meet the high clinical workload. But we explained to our surgical colleagues, we actually have to have these meetings. So we've gotten them going again. We have departmental protocols. In 2010, we established subarachnoid block as the preferred anesthesia technique for cesarean delivery. In 2011, the safe surgery checklist was implemented. And Dr. Harvey has spearheaded year-round basic life support and advanced cardiac life support courses. And currently, right now, she's in charge of the LifeBox pulse oximeter training, and Monica is in charge of its distribution nationwide. We did in-service training of the recovery room and intensive care nurses. We partnered with the Washington-based health volunteers overseas to launch a 2-year nurse anesthesia training program. 20 graduates were produced by the year 2000, and they were posted to various district hospitals nationwide. Problem: they got a lower salary because of the way their on-call was calculated versus overtime when they were regular nurses. So some of them opted to stay as a regular staff nurse rather than as a nurse anesthetist. They were relatively isolated, no opportunities for continuing professional development, remote faculty support only when solicited. Monica and I both migrated shortly after. She went both to Caribbean territories. She had 5 children, so she went to get them all sorted out with their tertiary education. And after everybody had gone off to university, she returned to Guyana. I left and got married to my Nigerian doctor husband, and he took me around the world. And then another call from Alex. They finally approved our request for postgrad training for the anesthesia doctors. So left Kenya and went back to Guyana for that. When we returned in 2008, only 2 of that cohort of 20 nurse anesthetists were still there, and they were the ones working in the private sector. The others had all migrated. So anyway, we resumed training more nurse anesthetists, and at that time, the Ministry of Health were pushing for nursing assistants to be admitted into the program. But with the help of the Nursing Council, we were able to win that boxing round too. As in most disciplines, the majority of our specialists are foreigners, and the number of anesthetists over the years has doubled, but remains woefully short of the 60 providers recommended by Dr. Odwin Segal in her thesis. And her calculations were based on the population, number of surgeons, and roles and responsibilities of our anesthesia providers. In 2009, after we had the program approved, we took our first applicants into the anesthesia diploma program for doctors. And the first 4 candidates all dropped out of the program. The first, because of the academic load. The second, because of the clinical load. The third got a green card and migrated to the US. And the fourth had a problem with the terms of the contract bond by the government. But we hope to produce our first graduates next year. Anesthetists, we do not work in isolation. And I have to say it has been a wonderful pleasure to witness the growth and transformation of doctors in other specialties as they have benefited from excellent tutoring delivered by foreign specialists. There's a but. What is the paper value of their degrees? How do they measure up against peers in other countries? And most importantly, has this benefited the people of Guyana? Are they healthier than they were before? And when I look at surgery, our surgical graduates can expertly perform mastectomies. But the more important question is, are our breast cancer patients having improved outcomes? Because surgeons cannot work in isolation. You need the oncologist, the pharmacist, the histopathologist, the radiotherapist, the medical technologist, the radiologist, and the nurses. Are they also performing their roles expertly? If you have one gap or one link, you will have a poor outcome. So, are we better? All the initiatives over the past 2 decades, does our data support the hypothesis that these have contributed as anticipated to improved health of our citizens? As Margaret Chan, the Director General of WHO, stated, the best measure of a health system is its impact on health outcomes. Well, our children are doing better. And I'm comparing us with Trinidad, Tobago, Jamaica, and Barbados, since we are originally four of the more developed Caribbean territories. Our infant mortality rate is getting better, yeah. Cancer survival, not good. And the regression models predicting that within 5 years people die. The person who was head of the Cancer Society in Guyana, he said, oh, once you have cancer, you are dead, you will die. Our life expectancy, the Minister of Health in 2007, in signing in his foreword to the package of publicly guaranteed health services, anticipated that by 2012, our life expectancy would be 70 years. It's going in the wrong direction. The government's figures for maternal mortality are very different from these. These are from the Global Health Observatory, which is WHO, World Bank, UN, I think PAHO. So it's a number of agencies have come together. And the anticipation was that by now our maternal mortality ratio would be less than 100. It seems to be going in the wrong direction. And 2013, it started to go in the right direction. So we're now at 230 per 100,000 live births. And it is the third worst maternal mortality ratio in the entire Western Hemisphere. And I always wonder if young women are going to die from a limited number of things. We know the leading causes of maternal death. What happens with the sicker persons in the society? So I encourage you to think of a training program, not as an endpoint in itself, but rather to contextualize it within a health system and to recognize that if the health system is not strengthened, then the training program may not achieve the desired results. And the World Health Organization has defined 6 building blocks for an effective health system, and they have put strengthening of health systems high on their agenda as a priority issue. Leadership and governance. Our policymakers need to show transparency, responsibility, and accountability. Regulations must be implemented. There needs to be an appropriate, achievable strategic plan with rational, logical, evidence-based policy decisions. Health information systems rely on good documentation with timely, accurate data analysis and feedback. Monitoring and evaluation of smart indicators. The latest morbidity and mortality statistics we have for Guyana are from 2009. And data can never be released until it has been sorted out by the powers that be. Health financing. There must be efficient, transparent use of funds with regular audits and opportunity for public review. In my cap as chair of the Quality Assurance Committee at the Georgetown Public Hospital, years ago I had recommended to the hospital authorities that there should be a forensic audit. And I actually went further and approached the Auditor General requesting same. It wasn't until things got very visible to the blind that the audit was conducted. The greatest challenge with human resources is the retention of adequate numbers of skilled staff. And that in itself is one entire conference to discuss retention. Supportive systems need to be created and an enabling environment maintained. People keep thinking that persons leave because of money and the salary. That is not usually at the top. And we did have a study in Guyana, and again, it was not at the top. But I think the best illustration was the taxi driver yesterday who said, stay in Canada, don't go back home. It is safe here. The law, if you break the law, you suffer the consequences. There are regulations which are implemented and have to be upheld. Stay, it is safe. Your children would be safe. It is a good place. It is expensive. So in other words, it wasn't about the money. Those are not the first issues persons think about when leaving. Essential medical products and technologies require a regulatory system and inspectorate and national diagnostic and treatment protocols. And for service delivery, we must ensure safe, effective, efficient, patient-centered quality care with provider accountability and an opportunity for the consumer's voice to be heard. I, therefore, wish to advocate the following when contemplating training programs in resource-limited countries. Consider addressing these World Health Organization building blocks in the Memorandum of Understanding with the recipient country. Our obstetric and gynecology program in Guyana at our hospital is an example where they made certain demands of the hospital to put certain things in place before the program could be started. Or establish your own center of excellence or health facility which has your university's standards, governance, and organizational culture. And that is how my alma mater, the University of the West Indies, got started. The vice chancellors in the United Kingdom had a meeting, and the University College of London decided to open a University College of the West Indies. And so it was started with faculty from the UK. 4 years later, it became a full-fledged university. The university is completely owned and run by West Indians, and it has several campuses now, and the student population keeps rising in a range of programs. So those persons from the 1940s can look and say, yes, we started this seed, and it has grown. Not only was it sustained, it has multiplied. It was how the University of Nigeria, of Ibadan in Nigeria was also started. And I suspect a number of other universities around the world. It is a model being used by Aga Khan University, which is in Kenya and Pakistan. The Cure Hospitals, and as mentioned yesterday, Cool and PACS. These are centers of excellence where training programs happen. In the curriculum, since it is anticipated that graduates will become leaders in their respective fields, inclusion of leadership, management, and change agent skills in the curriculum would be appropriate. They will be called upon as experts to analyze critical incidents. Years of anesthesia deaths could have been avoided if even one death had been expertly investigated and the recommendations implemented. Remember that graduates and local faculty require support for continuing professional development. And creation of protocols and guidelines is an effective way of disseminating one's expertise. As chair of the Medical Council, I approached the program directors for the various programs, asking them to help with the creation of protocols for secondary and tertiary care to be approved by the Ministry of Health and then disseminated nationwide. And they have started working on that. And in terms of the program development, monitor and evaluate the program and its health impact. You need timely data analysis and feedback, and maintain quality assurance not only of the program, but consider establishing a system for periodic revalidation of the graduates, and groom graduates to become future faculty for self-sustainability. In conclusion, please remember that our ultimate goal is to improve people's health. The health-seeking behavior of persons in lower-income countries is such that patients may tend to present late. And further, health workers may miss the diagnosis initially, either due to less clinical expertise or inadequate or inaccurate diagnostic support. So patients with advanced pathology in resource-limited settings need very well-trained staff. And a training program without a sustained, supportive, enabling environment which allows graduates to use their new knowledge and skills will have less health impact. And this is the thing with the WHO, the 6 pillars that I mentioned earlier. You can get it from the WHO press. And I just say Tekun Kura, which is thank you in Amerindian. Thank you.